Hello everyone, today we're going to talk about hyperkalemia and the treatments that go with it and whether or not we should or should not be doing them. Let's give it a look. Remember, when we discuss hyperkalemia, we're looking at the potassium content within the blood. Now, a majority of our potassium is going to be found within the cell itself, about 150 to 160 milliequivalents. However, the blood content, the very small amount, is what we're measuring here. It's also very important to remember that the kidneys are what are responsible for excreting majority of our potassium. About 95% of the potassium is dealt with through the kidneys, more specifically in the distal nephron by cells like principal cells and intercalated cells that have everything to do with aldosterone. So the majority of people that have hyperkalemia have some degree of renal failure or an acute kidney injury. Usually, if potassium is rising slowly, the kidneys can deal with that and secrete more potassium. The concentration and gradient of potassium is also obtained by the sodium-potassium pump. This pump requires oxygen and energy. What it does is it moves the ions against their concentration gradient. 3 sodiums out, 2 potassium in. This pump is essential for keeping the resting membrane potential of the cell, which is why potassium is so essential for that. Now remember, the sodium-potassium pump needs oxygen because it's an active pump. It goes against its concentration gradient. If we have no oxygen with hypoxemia or shock, the potassium will simply leave the cell, as it has a higher concentration gradient within inside the cell than outside. Therefore, it'll want to leave the cell, and this pump will not work and not keep our potassium in check. Though there are many more pumps that keep potassium within its gradient, the potassium hydrogen pump is another very important pump. This is when acidosis happens and we have increased hydrogen content in the blood, it'll switch places with potassium, both being cations, bringing in the hydrogen and leaving the potassium within the blood. For that reason, metabolic acidosis can be a cause of hyperkalemia. Along with metabolic acidosis, anything that causes the potassium within the side of the cell, which is a much higher content, to leak will cause hyperkalemia. Things like tumor lysis syndrome or any kind of trauma to break cells open. The cells are lysed, it releases potassium into the blood. Lastly, don't forget about aldosterone. Aldosterone is part of the RAS system. Aldosterone's main job is to increase sodium and water retention and help secrete potassium. Anything that blocks this system, like an ACE or an ARB, or anything to lower your aldosterone, like hyperaldosteronism seen with Addison's, can lead to higher potassium levels. Now let's talk about eating potassium. If a patient eats a ton of bananas in one day, they should not suffer a hyperkalemia crisis. Now that's as long as their kidneys are working. If their kidneys are functioning, it should be able to filter out the potassium because the levels or the intake is not exceeding the filtration rate. Let's talk about some of the signs and symptoms of hyperkalemia. Everybody likes to talk about the EKG. A lot of us know about the classics. We can have a wide, flat P wave. We can have a decreased R wave amplitude, prolonged PR, widened QRS, tall peaked T wave, and depressed ST segment. However, there's a lot of literature on this. No one can really agree on a number or if this really goes in order. So it's difficult to say what you're seeing on the EKG and what's going to come up next. So that doesn't mean if you just see peak T waves not to worry, because your patient could go into a bradycardia very, very quickly. It's not so much the patient's number as their potassium, it's the rate in which that potassium rises. We call this potassium adaptation, which is the ability of the body to adapt to increased levels of potassium over time. A sudden increase in potassium level may be fatal, but if the intake is slowly increased, then the body has the ability to filter that potassium out. Again, this is with kidneys that are working. However, think about a chronic renal failure patient. Their heart is constantly in a hyperkalemic state. Their body adapts to this. However, if you're someone that's not used to a high potassium and your potassium cranks up very, very fast, then you might have problems. This is why the chronic renal failure patient might have no EKG symptoms with a potassium of 6, but someone that does not have chronic renal failure and all of a sudden has a potassium of 6 might have multiple EKG findings. It is different for each patient. Talk about what actually goes on with the heart. If you remember, the heart is hypopolarized, meaning it's more positive. If you remember, the resting membrane potential is a negative number, and that all comes from the sodium-potassium pump. There is more cations leaving the cell, aka sodium, than cations entering the cell, aka potassium. Therefore, it's at a negative resting membrane potential. When there's more potassium outside the cell or that leaves the cell into the blood, the cell then becomes more positive, thus making it easier to have action potentials. This cell is then more hyperexcitable. With relatively mild elevations in potassium, the heart becomes more irritable. The action potential is initiated more rapidly because the cell is hypopolarized. However, as the potassium continues to increase, that resting membrane potential gets closer and closer to the threshold potential. When that happens, the heart is losing its ability to repolarize. That's where it gets very scary. So when the cell is not able to repolarize, it's not going to listen to any external stimuli, and eventually we get cardiac arrest. So let's kind of look at what we're talking about here. The potassium is what gives us the resting membrane potential, which is right around negative 90. Calcium, however, gives us the threshold potential. That's what the cell needs to reach in order to have an action potential. Now, when the cell is hypopolarized, there's more potassium. Remember, we're more positive. Therefore, my resting membrane potential is going to go up or become more positive. Therefore, the distance between my resting membrane potential and my threshold potential is very minimal, which means it's very easy for that heart to have an action potential and to have many of those action potentials. As it gets closer and closer and closer, we lose that time for repolarization and we can have cardiac standstill. So the question is, what do we do? And this is one of our first treatments we're going to talk about. We give calcium. The calcium will therefore increase our threshold potential. Okay, so it's going to push that number even more positive because our resting membrane potential is now more positive from maybe negative 90 to negative 60. So we need to push our threshold even higher by creating a bigger distance between my resting and my threshold potential. I can lessen the effect of that potassium, therefore giving that heart some time to repolarize and actually relax. That's why calcium is the number one thing we do and one of the most effective things we can do to help out that heart. Some other things we can do is insulin, which will help push potassium back into the cell, not forgetting to give your dextrose with it, and a beta agonist, such as albuterol. Now, there is some data that shows that some people just don't respond well to albuterol, but if you're going to go all in, give the albuterol and keep pushing with it. Next, we're going to talk about a very famous drug to give, which is sodium bicarbonate. There's been some talk about sodium bicarbonate and whether it's really helpful with hyperkalemia. However, the idea of sodium bicarbonate is it should make the blood more alkalotic, therefore switching out the hydrogen with potassium. There is some debate if bicarb works if you're not in an acidotic state, but the point of it is to help switch out the hydrogen potassium. It also can help alkalize the urine and help secrete more potassium when given. However, there is a phenomenon called solute drag, which causes the cell to shrink and increase the plasma tonicity, which increases the intracellular potassium and then pulls that potassium into the blood. This is because normal sodium bicarb that you have in the amp that you give during a cardiac arrest is hypertonic. It will increase the tonicity of the blood. Therefore, there's a chance it'll pull sodium and fluid with it and also bring potassium with it. Shout out to Palmcrit and Josh Farkas for this amazing idea. So the idea is if you're going to give bicarbonate, maybe give just isotonic bicarb, which is 3 amps of bicarb in a hypotonic solution like D5 water or 0.45%. Lastly, always remember to not give your calcium chloride and your bicarbonate together. They will actually form a precipitate called calcium carbonate. So always make sure you're giving a nice flush through that line. Next, let's talk about K-exalate or sodium polyesterine sulfonate. Probably said that wrong. Basically, what this is an exchange resin. It's going to exchange sodium for secreted potassium. And most of this exchange takes place in the colon, which is also one of the sites for most potassium secretion in the gut. The use of K-Xylate makes sense, however, its efficacy in acute hyperkalemia management might not be the best. This is because K-Xylate is given orally or as an enema and takes quite a long time to peak to actually get the potassium off. Hopefully, with its half-life of 2 to 6 hours, you would hope that you would have this patient hopefully more corrected. Therefore, K-Xylate seems like it's better in the chronic management of high potassium, not acute. Lastly, we got to get the potassium out of the body because most of the things we're doing before just moves the potassium in and out of the cell and changes it with some electrolytes and moves it around the body. Outside of bicarb making the urine more alkalotic, we got to still get the potassium out. We got to stop shifting around and get it out of there. So we can either give diuretics or we can do dialysis. Giving a diuretic to patients that's anuric might not work, but it's something people might try, and we're always moving towards that dialysis, especially for our renal failure patients. They especially need this the most. Again, we got to remember to get the potassium off the body. We've given the important drugs, we've given the calcium, we've given other things, but we still got to get it out of the body, or it's just going to come back out of the cell. Ultimately, what do we need to do? Like anything in medicine, treat the underlying condition. What is causing the hyperkalemia? If we don't change that, the body will just continue to be in whatever state it is and continue to make more and more potassium. Therefore, treat the underlying condition. And that's all I have for you today. Thank you so much for listening, and hit the like button if you enjoyed it.